Okay, welcome everybody to tonight's presentation, Molecular Residual Disease Clinical Applications for an Emerging Technology. Tonight's speaker is John Strickler, Associate Professor of Medicine at the Duke Cancer Institute and co-director of the Molecular Tumor Board. John's going to give a nice overview, which I've previously heard, as well as update us on the results from the Circulate clinical trial that were presented recently at ASCO GI. And John, with that, I'll turn it over to you.
Great, thank you so much, Charles, and pleasure to be here tonight and to meet all of you. Let's start first with the current state of survivorship and surveillance according to the NCCN. And when you go over then and now, this is our 1996 NCCN guidelines shown here, with the core components shown here: physical exam, CEA, imaging, and colonoscopy. And it's amazing how little has changed. And yet in 1996, they said post-treatment surveillance of patients with colon cancer is a controversial management issue. And despite the fact that our surveillance guidelines were built on pretty shaky foundation, here we are over 25 years later with basically the exact same components of surveillance that we had back in 1996: physical exam, imaging, colonoscopy, and CEA. But I'm not a big fan of CEA. If someone is a big defender of CEA on the call today, I'd love to hear their perspective. I think it's a problematic biomarker. We don't know the right cutoff. There's a lot of true positives, a lot of false positives. That was shown very clearly from a series from Memorial Sloan Kettering, where they looked at 728 consecutive patients who underwent R0 resection for stage 1 through 3 colorectal cancer between 2003 and 2012. All patients had a normal perioperative CEA level, but subsequently had at least one abnormal CEA measurement. And the outcomes are shown here for the positive CEA. Nearly half, or 49%, had a false positive. 46% had a true positive, so there were more false positives than true positives. And there was a small sliver of patients who had a true positive, but it was a new non-colorectal cancer. And the appropriate cutoff for CEA is unknown. We have more false positives than true positives, up to 10. At the cutoff of 5, which was used at Memorial Sloan Kettering in this analysis, the sensitivity was only 54% with a specificity of 79%. And the statisticians at Memorial Sloan Kettering said that if you were to calculate the optimal CEA cutoff based on an ROC curve, that would set it at 7.9, which would bring your sensitivity down to 44% with a specificity of 95%. So despite the fact that this is an inherently flawed marker, it is a core component of how we do surveillance. I'll point out that this is our NCCN guidelines for, as of today. I just went and looked it up. So this is the most up-to-date version. And you can see for stage 2-3 colorectal cancer, CEA is advised every 3 to 6 months for 2 years, and then every 6 months for 5 years. Now, they do have guidelines in here for what we should do if there is a elevated CEA. And so if you advance to the next part of the NCCN guidelines for serial CEA elevation, they're recommending that we go back and scan again. And if that's clear, to go ahead and order a PET scan. Now, I happen to live in a geography where insurance is not a big fan of PET scans, particularly not for colorectal cancer. So this sometimes can lead to peer-to-peers, and not to mention the fact that having an elevated CEA is very stressful for patients. And frequently these are false positives. So we're doing a lot of excessive testing with, quite frankly, with spurious results. So this is where we stand right now with surveillance and survivorship for stage 2-3 colorectal cancer. Our guidelines are based on a shaky foundation from 1996, and they had very limited supporting evidence back then. The core components of surveillance, CEA and CT, and their test intervals really have never been truly optimized for survival benefit. And in some cases may lead to inappropriate use of our healthcare resources. And there's an opportunity, I think, now that we have new technology coming to the fore to rethink our survivorship and surveillance and think about this more in an evidence-based way. So with that, I want to do a critical look at MRD as a decision-making tool in the adjuvant setting. So we all know the liquid biopsy. And oh, great, thank you for the comment as well. Trend of CEA, yes. So we not only do we look at the absolute number for CEA, we also look at the trend, and that's what we're all accustomed to coaching our patients. That, you know, we don't just worry about a 5.5, we get worried if it's been normal and then it's slowly marching up over time, absolutely. And so coming back to the presentation, many of us are quite familiar with the liquid biopsy in the clinic. We order it for various purposes. I think most of us are accustomed to ordering it for identifying actionable biomarkers, particularly where tissue is unavailable or you need a quick result. But what I'm going to talk about here is this liquid biopsy technology to detect molecular residual disease following resection. So when we talk about the term molecular residual disease, or MRD, it's really based on this notion that, you know, when a patient has clinically apparent disease, we're treating with curative intent, so in this case, surgery. And then after surgery, there may still be some tumor cells left. And if you can detect those cells by virtue of circulating tumor DNA, you can potentially intervene and maybe resect that or treat it with chemotherapy to eliminate whatever residual cells are there before the disease becomes clinically detectable. So you'll hear the term molecular residual disease or minimal residual disease, but I think the term molecular residual disease is really more commonly used. So there are a number of ways that we can detect molecular residual disease. One approach, which has the most validation in our literature at this point, is the so-called tumor-informed mutation detection. So the way this works is that the patient has a tumor that's surgically removed, and in this case, maybe a colectomy, and then that tumor is sent off for whole exome sequencing. And what they're looking for is a unique signature of tumor mutations that are only part of that tumor. And those mutations are not found in germline DNA or in any other compartment of the body, say the myeloid compartment or elsewhere. So from that tumor whole exome sequencing, you develop a custom panel of 16 clonal mutations that are unique to the tumor. And then you're looking for those variants in blood over time. So it's a personalized assay built off of that initial resection specimen. This technology has been evaluated for a number of years. And the first group to look at this was a research team out of Australia, Jeannie T and her colleagues. So here they used a tumor-informed assay that they built themselves in Australia. This was where they only looked for one variant in the tissue, not 16. And in this initial series, they took 230 patients with stage 2 colon cancer. All of them were treated with curative intent. And they looked at the ability of circulating tumor DNA to project recurrence, and found that patients who were positive had a substantially worse prognosis than those who were negative at the single postoperative time point. So 18-fold more likely to recur over 2 years. When they compared circulating tumor DNA to clinical risk factors, postoperative ctDNA vastly outperformed traditional clinical risk factors, things like T stage, lymph node status, and lymphovascular invasion. And interestingly, postoperative CEA, at least in this series of 230 patients, was unable to predict recurrence and with a p-value of 0.52. So The challenge, of course, is that that was a research assay. Natera is a company that has developed a tumor-informed assay that's commercially available. I'm sure many of you have already ordered it in the clinic. If not, love to hear your perspective on the data and how influential it is for you. So this was published in JAMA Oncology in 2019. It included patients with stage 1 through 3 colorectal cancer. All of these patients were treated in Europe, and they were treated with curative intent with optional adjuvant chemotherapy. They collected blood on the day of surgery, 30 days after surgery, and then every 3 months, all the way out to 3 years. And you can see the stage breakdown here. Most patients had either stage 2 or stage 3 disease. And when you look at the relapse-free survival for 94 patients with stage 1 to 3 colorectal cancer, this is based on a blood draw 30 days postoperatively. You can see a pretty wide separation of the curves where patients who were positive at that single postoperative time point were 7-fold more likely to recur than those who were negative. After completion of adjuvant chemotherapy, that's why these curves are together all the way out to 9 months. The curves separate even more, 17.5-fold greater risk of recurrence for patients who are positive versus those who are negative. They also looked at the impact of circulating tumor DNA status on at least longitudinal circulating tumor DNA status, where those patients who were ctDNA negative rarely recurred. So in fact, 2 out of the 60 ctDNA negative patients recurred, whereas 14 of 15 ctDNA positive patients experienced recurrence. So it really did show a pretty wide difference prognostically between those who are ctDNA negative and positive longitudinally. So next, we can see how in this same data set, how the circulating tumor DNA assay did against CEA, and the sensitivity for ctDNA outperformed CEA, 88% versus 69%. Specificity also substantially better for ctDNA, 98% specificity versus 64% for CEA. So, ultimately, we want to know what to advise our patients about a positive or a negative result and how to incorporate that into our care. This is something that I lean on when I'm talking to my patients about what a positive result means and what a negative result means. When you look at that postoperative ctDNA status or that day 30 blood draw, patients who are positive had an 80% risk of recurrence or a 20% relapse-free survival. And that goes up to an 87% relapse-free survival off that single postoperative time point. At the end of adjuvant chemotherapy, we see relapse-free survival of 17% if positive, 88% if negative. And then with longitudinal monitoring, we really do see the power of the ctDNA assay, 97% relapse-free survival if you're negative for 3 years versus 11% for those who are positive. I suspect that this 11% will eventually turn positive, but just, or at least will eventually have recurrence detected radiographically, but just hasn't had it happen yet. Any questions about this data? So ultimately, what we want to do is integrate this MRD testing into clinical care and show that this has utility for us, that it can improve our ability to detect recurrence and our ability to potentially render a patient disease-free. So, one application would be to select high-risk patients for aggressive therapy when postoperative observation might be standard of care. And another potential application would be to spare our patients chemotherapy or treatment if there's no residual disease. Now, we've not yet accomplished this vision, but that's where we're all headed with this type of data. So with that, I want to, we've got a question. Am I pronouncing your name right? Dr. Ikaha?
Yes, you got it.
All right. Why don't you go ahead and ask your question for the group? Or I'll ask it for you. Did the ctDNA negative patients that recurred convert to positive at recurrence? If so, how long after conversion to positivity? Great question. So basically, what they found in that initial data set that was published in JAMA Oncology, and I didn't highlight this, but I will, is that the mean lead time to recurrence was 8.7 months. So if it's positive, on average, it's detecting recurrence about 8 months before a scan. Now, I will point out that one limitation of this data set is that this was in Europe, where imaging is much less frequent in intervals. This number is, if you see here, this is how the Europeans were doing this imaging at 12 months and 36 months. They're much more conservative about imaging there. So there may be a little bit of a regional difference in that number, but that was what they found in this data set. In terms of whether this data is covered by insurance, that's a question I just got from Nirma. I don't know if they blended your name together in Zoom.
It's Nirmala Nathan. That's okay.
All right, Nirmala Nathan. I didn't want to misspeak. So the question is it covered by insurance? Charles Weaver, you've done some research on this. I don't know if you're available to answer that question.
So Medicare made a coverage decision some time ago, and it's covered by Medicare. Most payers are covering it now. And if it's not covered, I do know that Signatera runs the test for free. But obviously, like everything else, it does go market by market.
Yeah, and I will say this. I've ordered on a fair number of patients, and I have not yet had a bad billing experience. Has anyone on the line today had a billing experience less than positive billing experience so far?
That's an open-ended question.
Yeah, I don't know if anyone has, please jump in. I have yet to have a patient angry at me about a bill. Now, I will say, in my geography, I do get a lot of billing problems for my tumor NGS testing, but I've not had it for this yet. So knock on wood. With that, let's go ahead and jump into a case, because I want to make this more case-based today, so that I can keep Steve Cohn entertained. Let's start. So let's start here with this case. I don't know who submitted this case. So it's a 49-year-old male with a history of diabetes, hypertension, family history of Lynch syndrome, diagnosed with an MLH1 mutation. Presumably that is this patient's Lynch mutation, or its germline. This patient had regular colonoscopies and presented with a GI bleed. Colonoscopy confirmed a poorly differentiated adenocarcinoma. The patient underwent subtotal colectomy, 16 lymph nodes were negative, and it was a T3 tumor. So it's T3N0, but there is lymphovascular invasion. And the question is, can this patient with T3N0 MSI high colon cancer, stage 2 colon cancer with lymphovascular invasion, benefit from chemotherapy? Does anyone have a strong opinion about this before I dive into some slides?
Yeah, I'm not sure if you can hear me.
Yes,
but I think my first concern is, the suggestion of a lack of benefit to 5FU and T3N0 patients with MSI high status. Now, whether Signatera type ctDNA assay would differentiate those who may benefit or not, is unknown to me, but it'd be nice to see those data in that regard.
Right. I think that's a great point. And I think then the question is not only would the patient benefit from chemotherapy, but if the circulating tumor DNA came back positive, would you give FOLFOX chemotherapy, or would you give, per Keynote 177, pembrolizumab immunotherapy? And I think that's a question that we could have a robust discussion about, but you know, let's go ahead into some of the data here. I think many of you are active medical oncologists, and the data for the adjuvant treatment of stage 2 colon cancer is problematic, to say the least. This is the Quasar analysis published many years ago, back in 2007. And just as a reminder, this was a study of over 3,200 patients with colorectal cancer. 91% had stage 2 disease. So it was mainly stage 2. Now, overall, it did have a signal towards benefit, but it was mainly out of the stage 3 patients. In fact, in the stage 2 patients, there was no advantage to adjuvant 5-FU. And that's problematic, obviously, because you would love to give adjuvant chemotherapy to at least to our higher risk patients. The other question is, well, maybe if we just add on oxaliplatin in our patients with stage 2 colon cancer, maybe that will give benefit. And that's, you know, Mosaic trial, among others, have shown that there's no benefit to giving FOLFOX in patients with stage 2 colon cancer. At least it adds nothing on top of oxaliplatin, does not add a survival benefit when added to 5-FU, at least for patients with stage 2 disease. That survival benefit is pretty much limited to our patients with stage 3 colon cancer. And then, you know, we oftentimes will consider adjuvant chemotherapy in patients with higher risk stage 2. Those high risk features could include T4, tumor perforation, or low lymph nodes from the surgical specimen. And in fact, even in the Mosaic trial, there was no benefit from the addition of oxaliplatin to 5-FU in patients with stage 2 disease with high risk features. So we've got, you know, very weak evidence to support adjuvant chemotherapy in patients with stage 2 disease. I just snipped this out of our NCCN guidelines just because if they had changed something up, I wouldn't want to mispresent the data. But when we go to this case just presented, this is a patient with T3N0 and T3N0 right here, MSI high, and they're recommending observation. And that's really based on a number of studies over the years showing very limited benefit for 5-FU by itself in patients with MSI high disease. And interestingly, it does not appear that high-risk features like lymphovascular invasion impact the NCCN guidance. So the NCCN is saying we would only consider high-risk features in patients with stage 2 disease with a high-risk feature. But if they're MSI high, you would not incorporate those high-risk features. So now high-risk features by NCCN, of course, are poorly differentiated, histology, lymphovascular invasion, bowel obstruction, less than 12 lymph nodes examined, perineural invasion, perforation, or positive margins. So, you know, one of the things that I struggle with as a GI oncologist is that, you know, the NCCN guidelines and our standard of care nationally tells us to incorporate prognostic factors into our adjuvant decision-making, at least as it impacts stage 2 disease. So things like CEA, lymph nodes examined, margins, perineural invasion. So if we're incorporating these prognostic factors into our decision-making of whether to give chemotherapy or not, where does ctDNA status fit? You know, first, do we consider this to be a strong prognostic factor? And if so, why do we keep this very strong prognostic factor out of our decision-making for a patient with stage 2 disease? If anyone has an opinion about that, I can stop for a moment, but if not, we can go into the Galaxy data. All right, so, you know, I have to give credit to the Japanese for launching the Galaxy and Circulate Japan study, which is really the best data set we have so far on how to incorporate circulating tumor DNA into our practice, how to understand the prognostic impact of these results. And it's given some clues as to how we could potentially incorporate this data into our practice. So with that, I'll go ahead and review some of the data they presented at ASCO GI in January. So as a overview, Circulate Japan was primarily focused on understanding the clinical utility of MRD for patients with stage 2 through 4 colorectal cancer. It actually included patients with all stages, but it was, primarily built around identifying patients with stage 2-3 disease. It has a couple of interventional arms. One is the so-called VEGA trial, where they take 1,240 patients who are post-op ctDNA negative and randomize patients to either CAPOX for 3 months, which would be standard of care where it's indicated, or no chemotherapy at all. They also have this ALTAIR trial, which is randomizing 240 patients with ctDNA positive disease to additional TAS-102 or placebo intervention. But the Galaxy study, which I'm going to show here, we'll have to stay tuned for VEGA and ALTAIR at a future meeting, but this is the Galaxy study, which is for all the patients that didn't go on VEGA or ALTAIR. This is truly an observational cohort where they draw blood before surgery, 4 weeks after surgery, then at 12 weeks after surgery, then every 3 months, up to 5 years. So the Galaxy study uses the Signatera assay. The blood samples are collected at those time points I just mentioned. Sorry, I think they go all the way out to 3 years, not 5 years. And the goal was to feed the VEGA and the ALTAIR trials, but they also had a really outstanding observational cohort as well. And so they enrolled 1,500 patients between June 2020 and April of 2021. I think we would have a really hard time in the United States enrolling 1,500 patients on anything over 9 months, let alone an observational cohort like this. 1,000 of the patients, as shown here, were included in the outcomes cohort. And just to go over this, so they have 838 patients in what they call a dynamics analysis cohort, which I'll go into more detail. They have a clearance analysis cohort and a ctDNA negative cohort of 531 patients. And sorry, I'm not looking at the chat that frequently, but people are asking really great questions on the prior case. We'll come back to this question that you're asking in the chat. So in this short outcome cohort, we can see the gender breakdown that's pretty even. And at least in the post-op ctDNA negative, interestingly, there were more males that were positive post-op 4 weeks. And MSI status is shown here with most of the patients who were negative were ctDNA, I'm sorry, most of the patients who were ctDNA negative were MSI high, at least in this, were more likely to be MSI high, I should say that, so I don't misspeak. And we'll move on to the next. So this first chart here shows the prognostic impact of circulating tumor DNA status at the single time point 4 weeks post-op. So this is 28 days after surgery. The red line here represents those patients who are ctDNA negative. The black line represents those patients who are ctDNA positive. We can see that the 6-month disease-free survival is 97% for those who are negative versus 73% for those who are positive. And then that curve even separates further. So a 13-fold increased risk of recurrence for those patients who are positive at that single post-operative time point. So it is really showing a pretty wide separation of the curves. One limitation of this data is that the median follow-up time is only 11.4 months. This is fairly immature data. I suspect that as the data matures and we get further out from surgery, we'll see the curves continue to widen. when you look at various prognostic factors, traditional prognostic factors, the one that is most significant for recurrence is the postoperative ctDNA status. So hazard ratio of 15 for recurrence for those who are positive. And that's has much greater prognostic power than any other factor looked at, although I'll point out that BRAF mutation status also predicted poor prognosis, as did KRAS mutation status. So from that, I want to move into this dynamics analysis cohort. This is a large cohort of 838 patients. And the way this cohort works is they look at the dynamics of circulating tumor DNA from the single postoperative time point at 4 weeks to the 12-week time point. And they look at the impact of the change on disease-free survival. So up at the top here, these two groups of patients with the lowest risk of recurrence are those patients who either were negative on 2 occasions, so 6-month disease-free survival of 98%, and those patients who are negative twice. But look here, at the single postoperative time point, if you were positive and then flipped to negative at the 12-week time point, your disease-free survival is almost identical to being negative twice. And then we've got this unfortunate group of patients who are in red, so they started negative and they flipped to positive. They had a much worse disease-free survival at 62%. And then the worst prognostic group is those who were positive twice with a 58% 6-month disease-free survival. So this really tells us the prognostic impact of this data. The next question is, can we change the outcome of these patients by clearing the circulating tumor DNA out? So if they're positive and we flip them to negative, is that, what does that tell us about these patients in terms of their prognosis? So this is the clearance analysis cohort as shown here. It's a smaller cohort of patients, tends to be more heavily male, who did not get adjuvant chemotherapy at least. So they look at 2 groups here in this clearance analysis, those who got adjuvant chemotherapy, 96 patients, and those without adjuvant chemotherapy. And when you look at the clearance rate, we can see that with adjuvant chemotherapy, the clearance rate, the rate of clearance was 9-fold higher for those patients who got adjuvant chemotherapy compared to those who didn't. So an impressive result showing that actually when you do have ctDNA status, ctDNA positive status, you're far more likely to clear out that DNA by virtue of receiving adjuvant chemotherapy. Now, this is an observational cohort. It is not an interventional, it is not a prospective randomized trial. So there's probably some selection bias in here, but I do think the data is meaningful. When we look at the various factors here, once again, receipt of adjuvant chemotherapy is the strongest factor that may predict clearance of circulating tumor DNA, but it also shows that adjuvant chemotherapy gives the patient the, I think what this is saying is that if you don't give adjuvant chemotherapy, the risk of recurrence is greatest in this data set. Interestingly, RAS mutation status also came out as a risk factor for recurrence in this small patient population. The other thing we look at is disease-free survival in patients who are ctDNA positive. They get adjuvant chemotherapy, and with adjuvant chemotherapy in these positive patients, you can see much better disease-free survival than in those patients who don't get adjuvant chemotherapy. So this data would suggest to us that we can act on the circulating tumor DNA status, and that this should drive the decision to give adjuvant chemotherapy, at least out of this observational data, because the disease-free survival is substantially better where adjuvant chemotherapy is given. All right, so let's move back to the case. Yeah, go ahead.
Just we had a quick question on timing. Can you just say a word about timing of the test and how late you can go back and order the test?
I think this is a great question. I think, you know, all of the studies I've shown here follow a very rigorous schedule where blood is drawn generally 2 to 4 weeks after surgery and then followed in a rigorous manner. When you actually get into the real world setting, it's rarely done like that. And most of us would order circulating tumor DNA at any point in time. And as long as that tumor tissue has been adequately preserved, you could order this MRD test 5 years after surgery. And I actually can give an example of that in a case to come. But no, I have no concerns about ordering the test long after surgery is over. So, you know, I think what these observational cohorts do is they allow us in a very kind of organized way to understand the prognostic significance at various time points, but it doesn't mean that you can, that we should feel limited to just ordering the test, you know, at certain points in time. And if we miss the window, it's of no value any longer. Any other questions? So let's go into this second case. This is a 47-year-old male with diabetes, non-compliant. So we're definitely not going for Xeloda for this guy. High risk right-sided colon cancer, stage 3C. So it's T3N2B. Adjuvant chemotherapy was delayed after right hemicolectomy and then completed in April of 2021. And the question is this a good candidate for ctDNA monitoring? And what's the data to support management if he's positive? I think that question was answered with the data I just showed you, which is that if the DNA were positive, he would have a much greater opportunity to clear that circulating tumor DNA if he received adjuvant chemotherapy, and his disease-free survival would also be better if he's positive and got adjuvant chemotherapy. But I'm actually going to ask the inverse question, which is, if he's MRD negative, can he still benefit from chemotherapy? So what happens if this non-compliant guy with high-risk stage 3 disease is negative? What is the value of adjuvant chemotherapy here? Is anyone familiar with this data from Galaxy? I can show you what the Japanese presented and earlier this year. So let's look here at this ctDNA negative cohort and how they did with adjuvant chemotherapy. So this is a pretty large cohort. Remember, this is patients who are negative at that postoperative time point, 4 weeks post-op. I will point out that this is exclusively patients with high-risk stage 2 disease and stage 3 disease. So the patient in this case here squarely fits, you know, the bill for this observational cohort. And this is the data that the Japanese showed us. So once again, this is over 500 patients who either got adjuvant chemotherapy or did not get adjuvant chemotherapy. All patients had stage 2-3 disease. And we can see the 6-month disease-free survival is identical whether these patients got adjuvant chemotherapy or not. So 98.6%, 6-month disease-free survival with adjuvant chemotherapy, 97.5% without adjuvant chemotherapy. So no difference in these curves for a ctDNA negative patient, at least at a single postoperative time point. Any questions about this data? So, you know, it's a provocative question. Once again, this data is observational. It's not a prospective randomized trial. It's not telling you, I would caution any broad conclusions about this because it's not a prospective trial. But if this were to hold up in a clinical trial through Altair or Vega, I think this could be potentially practice changing for us, but I don't think we're there yet. So with that, want to go back to a case from my clinic. And this is an actual case that kind of shows the pitfalls of this and also the promise. So this is a 62-year-old female who presented to the ER with abdominal pain. CT showed a large ileocecal mass, small bowel obstruction, and there was also a cyst in the left hepatic lobe versus a metastatic lesion. We weren't really sure what it was. CT showed sub-centimeter pulmonary nodules, which were indeterminate, and colonoscopy showed a large mass in the right colon. Preoperative CEA is 3.0. They did a right colectomy, and this was a well-differentiated adenocarcinoma of the cecum, perineural invasion, invading visceral peritoneum, margins negative, no lymph nodes, T4A N0, with, as I said, high-risk features of being T4, perineural invasion, lymphovascular invasion. So let's first start with what we know about the prognostic, this patient's prognosis. So based on the MSK nomogram, 5-year disease-free survival without adjuvant chemotherapy of 54%. So actually has a pretty poor prognosis for someone with stage 2 disease. Additionally, when I look at NCCN guidelines on what to do with this patient, this is our updated guidelines. It says T4N0 MSS, this is her category. They're saying I can do capecitabine or 5-FU with no evidence that it improves survival. I could give her FOLFOX or CAPOX with even less data that it improves survival, or we could do observation. So Steve, help me out here. What should I do with this patient?
Hey, thanks for asking me the easy one. Yeah, well, that is a good question. I mean, I'm sort of thinking that, you know, given the nature of the talk, C sounds like a good possibility here. I think this is a potential avenue that we struggle with. And even the first case where you have some higher risk features, but then you have data really with limited benefit to chemo. So, this might be a patient where, looking for minimal residual disease would be particularly helpful. It sounds from the description, you're not going to get a whole lot more out of imaging. Everything's going to be a little bit wishy-washy. So I think there's lots of possible options, but I'm suspecting maybe for the purpose of this talk, we have C and we see what we got.
Well, she was pretty stressed out, Steve, about the situation, as you might imagine, otherwise healthy woman. And that tends to push us towards giving more aggressive chemo. I think many of us would give FOLFOX or CAPOX, right? To a patient like this with a 5-year disease-free survival of 54% or whatever it came out. I mean, I think that's a real accurate prediction. And so that tends to push us to be aggressive, and we can hurt people with chemo, right? So, it's a concern. And so what I said is, okay, let's order the MRD. And if it comes back positive, I will give you chemotherapy, we'll go all out. If it comes back negative, we'll either just do 5-FU by itself or Xeloda by itself, or even just go on observation. So we're waiting and waiting. She comes back a month later and the test is still pending. So Steve, I've got a test. I'm waiting on it. It's now we're 8 weeks out from surgery. She's anxious. And I'm still waiting on my result. And they're saying it'll be there tomorrow, but it won't be there tomorrow.
Right. No, I mean, I think you summarized the discussion perfectly. There's some patients where you discuss the data and the thought of not being aggressive drives them crazy. And then there's others that, if there's not a clear benefit to chemo, don't want anything to do with chemo. So right. I don't think you could go wrong with this high-risk stage 2 if you think about starting with FOLFOX or more likely Xelox for 3 months pending additional information.
Yeah, so I just said to heck with it. She was anxious. We'll just do K-Box, but if the test comes in negative and you're really not tolerating it, great, we'll just dump it, right? So we start the K-Box and it comes in negative. So now she's already on K-Box and I've got a negative MRD test, post-operative time point. So what do you do now? She's actually tolerating the K-Box okay.
Yeah, I guess in that setting, I mean, it's attractive to just think about completing the 3 months. I mean, I guess there's always a potential for a false negative. You know, although the data you showed are pretty provocative that she's going to do well regardless. But I think if she, as you point out, if she's tolerating it well, you know, I might think about finishing up the 3 months.
Yeah, that's what I did. I followed Steve's advice, and that's what I did. But you know, it's interesting to think about what if I had received that result. You know, how would things be different for her? Here in the US, we have the Circulate US trial, which is a large cooperative group study. This takes patients with stage 3 colon cancer. And if there's no circulating tumor DNA detected, patients are randomized either to adjuvant Capox or FOLFOX or just serial surveillance. So this is really the question that many of us have, which is, can we just skip chemo entirely in patients who are ctDNA negative? And in patients where ctDNA is detected, patients are randomized either to standard chemo, which is Capox or FOLFOX, or to an intensified chemotherapy, FOLFOXIRI. So, okay, so the question came up earlier. What if the patient was essentially missed that postoperative time point? Could we still use this assay? And so that's why I'm going to bring up another case from the clinic. This is a 38-year-old with stage 3 colon cancer who was diagnosed with T2N1 disease, had a persistently elevated CEA after surgery, and received adjuvant Capox as per the IDEA trial. But this patient had a CEA that surged after completion of adjuvant chemotherapy. And despite the fact that CEA, the CT scan was clear, the CEA just never normalized. So it persistently between 5 and 10. This patient did not want a PET CT because she was concerned about the radiation exposure from a PET. What she was willing to do was to get MRD testing. So here, you know, we discussed several options, CT, PET, reassurance, but decided to go with molecular residual disease testing. Now, her 5-year disease-free survival was substantially better than the prior case. Her 5-year disease-free survival was 84%. And we ordered this several months after the completion of surgery. And the first result, thankfully, was negative. CEA continued to bounce around between 5 and 10. And she has remained persistently negative now for several years. So this is an example where we actually used the MRD test to de-escalate anxiety, to provide reassurance, to avoid a lot of extra testing. And so this has been a real success for this patient. And so some final thoughts here. I know I'm running a little bit over. This molecular residual disease testing, I think, is a very powerful prognostic tool, but as many of you are asking great questions about the nuances of this, and in truth, we don't have all the answers to all the nuanced questions that we all have in real world practice. I personally think that if cost and convenience were not an issue at all, that this would be more broadly adopted. We quite frankly use a CEA test, which performs worse and have no concerns about applying that to our clinic. I suspect this is really something that, you know, if it were as easy to obtain as a CEA, I suspect we would be using it more. But there are clearly a lot of unanswered questions, and there are a number of studies ongoing to explore the clinical applications of this test. So stay tuned to the data and the evidence, and I hope Steve will join me again here after the next major meeting, because I'm sure we'll learn a lot more about how to use this test.